Next participant is Dr. Anupam Anand from NRSMCH.
Anterior urethral stricture. A 42-year gentleman from Chhapra, West Bengal, mechanic by occupation, married since 8 years, came with chief complaints of difficulty in passing urine since last 6 months, incomplete evacuation of urine since last 3 months, and increased frequency of urine since last 2 months. He was apparently all right 6 to 8 months back when he developed difficulty in passing urine, which was insidious and gradually progressive in nature. There was increased frequency of urine, and it was about 10 times during daytime, and nocturia was 2 to 3 times during night. There was history of straining during micturition. Sensation of incomplete evacuation of urine since last 3 months was present. There was no history of fever, dysuria, hematuria, perineal trauma, spinal surgery. There is no history of ulcer over penis. There is no history of perurethral discharge. In the past history of this patient is has that he had underwent circumcision at the age of 1 year, and there was history of he gives a history of catheterization 18 years back when he developed the AUR. There is a history of poor stream flow of urine prior to the AUR. Procedure was done. He has no documents available regarding the procedure, but it was probably a meatal dilatation. Catheter was there for 1 week, and then it was removed. After the removal of the catheter, patient used to pass urine spontaneously. But again later on in the later years, he started again developing poor flow of stream of urine. So SPC was done around 1 month back. There is no history of diabetes, hypertension or COX in the patient. Patient personal and family history are normal, not significant for this patient. In the general examination, patient is averagely built and well nourished. Karnofsky score is 100%, and vitals are also normal for this patient. Systemic examination was normal per abdomen. There was no palpable abdominal lump was seen. However, SPC was seen. SPC was there for the patient. Respiratory, CNS, and CVS systems were normal. Genital examination, penis was normal. Patient is circumcised. Pinpoint urethral meatus was seen. BXO change is present at the meatus. Urethra is firm, hard, cord-like, felt up to penoscrotal junction. Scrotal skin normal. Bilateral testis palpable, normal in size and shape. Oral examination, oral mucosa was normal. On perrectal examination, the grade 1 prostate was there, and focal neurological examination was also normal for the patient. Investigations, the routine investigations of complete blood picture, kidney function, liver function were normal. Routine microscopy of urine routine microscopy showed around 10 to 12 pus cells. However, there was no growth in the culture. USG KUB showed thickened bladder wall around 6.3 mm, prostate 19.1 cc, and significant PVRU of 84 cc. After that, uroflowmetry was done for the patient. Uroflowmetry showed a box-shaped curve with a voided volume of 590 ml and maximum flow rate of 12 mm per second. This is the uroflow, the curve of the uroflowmetry. CP was done, in which pinhole meatus was seen, which was dilated with meatal dilator, started from 3/4 French up to 6/7 French. Ureteroscope was used for urethral assessment. There was unhealthy whole anterior urethra seen. A short narrow segment stricture seen in bulbar urethra, which measured up at around 2.5 centimeter. URS could be negotiated through the stricture. Beyond proximally, the urethra was normal in the prostate. Prostatic urethra was normal. This is the graphical representation of the problem which he had. Around there was narrowing of 2.5 centimeter in the bulbar urethra, and the anterior urethra was unhealthy entirely. This is the ASU of the patient, in which we can see that there is the entire anterior urethra is abnormal, and there is stricture, very short segment at the bulbar urethra. MCU was also done for this patient. Posterior urethra is normal. There is no diverticulum seen in the bladder, neither any VUR is seen in the bladder. So the diagnosis was made for this patient as a long segment anterior urethral stricture. The options for the long segment could be substitution urethroplasty, fasciocutaneous flap repair, or stage urethroplasty. Patient underwent mechanic urethroplasty, circumferential penile fasciocutaneous flap. So this is the procedure. After giving an extended lithotomy position and spinal anesthesia, patient was the penile skin measurement was done, which was about 2.5 centimeter in width. So both the markings were made circumferentially marked with a pen. About 2.5 centimeter width of the penile skin was taken. After that, the distal skin was marked. The distal skin incision was marked up to the tunica albuginea, and then degloving was done up to the root of the penis. This degloving was this is how it was retracted. Then the proximal marking was done. The proximal marking is deepened only only the dartos fascia is lifted. It is deepened only till the buccal fascia. So the main fascia would be taken would be of the buccal fascia with a skin island flap over it. After that, we made a ventral incision over the flap in a plane where there was no it was avascular and no neurovascular bundles was not there. After that, the harvest flap length was found to be around 16 centimeter when we stretched the whole of the flap. Then we made a tunnel in the pineoscrotal junction which admitted at least 2 fingers, and then with a stay sutures taken over the flap, we rotated it and brought down through the scrotum. This is how it was anastomosed on the penile. The penile skin is being anastomosed there. This is the post-op, immediate post-op pics. After that, after 10 days, patient though developed some amount of discharge from the perineal, but it later on with antibiotic and culture sensitivity, it healed on itself. Catheter was removed after 6 weeks. MCU was done. We showed no leak. Finally, uroflowmetry was done. Initially, the uroflowmetry, the maximum flow rate for the patient increased from 12 ml per second to 21 ml per second. And the graph was also improved for the patient. Thank you, sir.
Thank you. Any question from the floor? Sir, Professor Kormukar has done many cases of the penile skin flap. And also Professor Chakravarti, why did you abandon this in favor of buccal mucosa? Because I have seen you have done, Professor Chakravarti did it during my MCH period, but afterwards I found that people shifted to buccal mucosal graft rather than this penile skin flap. Why? So we have to judge whether we shall accept the buccal mucosa or this, because there was some taboo that the urine has some reaction over the own skin.
Then yes, sir.
Now, this is a case of BXO.
Only at the meatus, sir. BXO.
No.
Yes, sir.
This is a case of BXO.
BXO, yes, sir. Yes, sir.
So we have to accept some. The whole of the panurethral inflammation.
Yeah, panurethral inflammation was there. Yes, sir.
So we have to decide whether we shall accept the, again we shall accept this preputial skin or penile skin, or advantage is that this is pedicle flap.
Yes, sir. This is pedicle flap.
And disadvantage of the buccal mucosa is the
It's a graft.
graft.
Yes, sir.
So we have to
So
decide.
BXO was only limited till the meatus. Yes, sir.
So you just tell what are the advantages and disadvantages. You have gone through the literature.
Yes, sir.
Many literatures are there. Yes. Even till now, there are many centers, they are accepting the buccal mucosa. Some centers, few centers, they are accepting the penile skin.
Yes, sir.
Most of the large centers, till now, they are So what are the advantages and disadvantages?
Advantages of buccal mucosa graft is that it is easily available, easier to harvest. Large segments can be harvested, and it is accustomed to wet surfaces. It has a thick lamina propria. It has a good resistance to infection. And the disadvantage that it is a free graft, so the bed on which it will be grafted needs to be vascular. If the patient has already went multiple surgeries in the past, then graft cannot be used. And also there is some morbidity at the donor site regarding in a graft site. And in a penile skin advantages are there that it can be done from the same sitting. There is no need to give GA for regarding that. And the disadvantage is that if the patient is circumcised or there is skin changes over the penile skin or it's a hairy, then we cannot use penile skin graft for this.
While in this case actually there is something as a technique. Here a technique was not done.
So we have to follow up. You have
Yes,
to
yes,
do
sir.
cases and follow up.
3 months,
Then
3 months,
final
yes, sir.
Result we shall get afterwards.
Actually, this is as a log segment stricture due to BXO or any other, particularly in case of BXO. So there is the DNA is a good option, no doubt, because we are doing the large number of cases. Even we have seen the workshop, that patient is also doing well, and we are not closing. We are not keeping in doing the DNA. We are not keeping the urethra closed. We are keeping a perineal urethostomy, because any time there will be a stricture like that. But in that case, we have just started the penile skin, so how it works, because we are planned for operation during the quiescent stage, because we are using the tacrolimus for when the patient come to OPD, we are using the tacrolimus in each and every BXO patient. So by the time the patient come in the OT by 6 months or 1 year, I think we take those patients which are become the quiescent, there is no active disease, and in that case we using because it is a pipicial flap, not a graft. Because we also using the BMG, but the result after 2 years is not satisfactory. So I want to compare this both. If yes, it needs a follow-up. And the original article from Mechanized, he has done from 1991, and the literature shows the 34 cases, and he has staged multiple because it is a long segment, more than 16 centimeter, 18 centimeter. So he used both flap and both graft. Graft is used mostly in the bulbar urethra, because there is a corpus spongiosum is much more, so there is a bed is. So when you because at a single stage, I think this can be considered for the timing, but long-term result is needed. And if you because it gives about 14 to 15 centimeter long, so it is quite long. And even if it is much more than 18 centimeter, I use the bovine pedicle for 4 centimeter in the bulbar part, and that result is also good. So I have to compare both these roads in a long run.
I think if you repair ventrally, where you cannot put the buccal mucosa, it will be very much helpful. This penile or penile skin flap, if you repair ventrally, any rent in the ventral part, you can put the
This
flap.
could be better than the ventral graft.
Because you difficult to put ventrally the buccal mucosa. Buccal mucosa may be done.
But dorsal, it is always dorsally, but you can place it on the bulbar region, you can place it ventrally.
Sir.
Because the bulbarly there is work on it, it works on the bulbar urethra, you may use it either dorsally or ventrally.
In bulbar urethra, where there is excess spongiosal tissue is there, you
Maybe
can use this ventral only graft easily.
But not for anterior urethral. So.
But buccal mucosa in other part,
No,
to put it ventrally.
Always
Not-
should with dorsal.
Dorsal. Yes.